Welcome everyone to the June 21st VLC, our Corrections and Viral Hepatitis 340B update, made possible in partnership with CDC's Division of Viral Hepatitis. My name is Michele Gard, and I'm the manager on the hepatitis team. Today we have presenters, Erin Fratto, HepTAC consultant, and Rob McGoey, Viral Hepatitis Prevention Coordinator with the Colorado Department of Public Health and Environment, and Michele Gard, clinical pharmacist with the Colorado Department of Corrections. The format for today's session is as follows. We will begin with presentations by Erin and Rob, followed by a moderated discussion. Feel free to use the chat to introduce yourselves and your jurisdiction, and if you have any questions. I wanted to note that we do have a change of date for the upcoming VLC. The next session will be held on July 5th. With a presentation and discussion held, led by Michele Gard, NASTAD on trauma-informed approaches for viral hepatitis. And so with that, I will turn it over to Erin. Thank you.
Thank you, Zakia. Right. Can everybody see my screen?
Yes.
Okay, perfect. Hold on, I lost my notes. Okay, there we go. All right. Hello, everyone. Thank you for joining. We're going to talk about the syndemic approach to 340B within correctional facility partnerships. This is for all prevention programs, but we're really going to focus on viral hepatitis programs today. So just to lay some groundwork and some terminology so we're all on the same page, I'm going to refer to correctional facilities throughout my presentation today. And when I say correctional facility, I mean any type of correctional facility, a jail, a prison, or other detention facility that's used to house people who have been arrested, detained, held, or convicted by a criminal justice agency or court. Within correctional facilities, there's also jails and prisons. And you're probably familiar with those type of correctional facilities. Jail is more short-term. Folks haven't been sentenced, and if they have been sentenced, the term of sentence is shorter. A prison is where an incarcerated individual resides once they've been convicted of a crime. State prisons are operated by individual states and are governed by legislation and statute at the state level. And there are also federal prisons, and those are overseen by the feds. So for correctional facility and 340B, and when we talk about all of that throughout the presentation today, the principles that I'm going to talk about are applicable to both types of correctional facilities. There's a few considerations, from one correctional facility type to another, but the basic principles and the 340B concepts are the same across correctional facility types. And again, I'm probably speaking to the choir, but more level setting. The prevalence of HIV, viral hepatitis, and STIs are significantly higher among people who are incarcerated when compared to the general population. There are almost 2 million people incarcerated in correctional facilities in the United States at any given time. For those of us who speak EPI, this is a rate of 565 per 100,000 people. So it's a lot of people that are incarcerated. We often make jokes that correctional facilities have revolving doors. The purpose of correctional facilities is rehabilitation. So the purpose is to get back into the community and contribute to society. So eventually the infections that are within correctional facilities will come back to the community. So this is really an opportunity to provide an intervention. Risk factors for acquiring viral hepatitis, HIV, and sexually transmitted infections are common among incarcerated populations. Folks who are incarcerated have condomless sex, multiple partners, substance misuse, and engage in commercial survival or coerced sex. Many individuals who are incarcerated have had limited access to healthcare before incarceration. Correctional facilities really are serving a safety net healthcare purpose. Folks might come in with infections, dental issues. They really may not have access to healthcare outside of being incarcerated. And most folks who are incarcerated have been battling a multitude of social determinants of health throughout their lives. It's also estimated that people who inject drugs comprise 50% of incarcerated individuals. In addition to all of these stats and facts, the CDC also provides specific screening, vaccination, and treatment recommendations for correctional and detention settings. This guidance gives guidelines for appropriate viral hepatitis, HIV, and STI-related services during intake and throughout the period of incarceration. So this really sets the stage well. This is a public health issue. There's public health guidance, and there's a public health reason and rationale to support interventions within correctional settings. 340B, if you have not had the opportunity to hear me talk about 340B before, I wanted to kind of put some basics up here on the screen. 340B is federal law that requires drug manufacturers to offer discounts on medication. To provide screening and treatment for viral hepatitis, HIV, and STIs, correctional facilities often need support from health departments. They need guidance and they need resources from health department prevention programs. When a prevention program provides the support in the form of direct funding or in-kind contributions from a federal funding source authorized by Section 318 of the Public Health Service Act, this partnership deems the correctional facility eligible to participate in the 340B drug pricing program with an STD designation. So you see here on the screen that I've outlined that there's 16 covered entity categories. Those are different CE types, and they're all authorized by different sections of the Public Health Service Act. There's the hospital types and the federal grantee types. The STD 340B designation falls under the grantee type. So today we're going to be talking about the STD designation specifically, and I'll talk a little bit more about what that means. But basically, participating in the 340B drug pricing program provides a correctional facility with access to deeply discounted medications that enable that correctional facility to contain prescription drug costs. And by doing that, they consequently maximize their budgets to expand testing, treatment, and care, and allows them to further address this endemic of viral hepatitis, HIV, and STIs. And it's important to note that correctional facilities are not 340B eligible on their own. 340B eligibility comes with eligible funding, and without partnerships, correctional facilities don't receive any funding on their own that makes them 340B eligible. So health department prevention programs often form financial relationships with correctional facilities. It might be a sub-grantee relationship, it might be an in-kind donation relationship, but this relationship really helps that correctional facility and provides services, whether it's through sub-grant objectives or in-kind services. And through those grants, subcontracts, memorandums of understanding in which Section 318 funding is provided to correctional facilities, STD 340B eligibility becomes possible. So this is all about relationships. This is all about passing on eligible funding or in-kind services, and also expanding public health services, all of the services that are within the scopes of your grants. All right, you've heard me talk about in-kind support. I think it's important to kind of describe what that is. In-kind support is qualifying in-kind contributions that must be paid for by Section 318 grant funds. This is what qualifies a site as 340B eligible. So when we're talking about viral hepatitis programs, partnerships with correctional facilities, the first step for 340B is ensuring a facility is eligible. Health department prevention programs often form financial relationships with correctional facilities to expand services, to offer services. Sometimes that's personnel to implement disease intervention services, partner services, outbreak response readiness, and other grant-specific activities and functions. Sometimes viral hepatitis programs will give an allocation of money to a correctional facility for specimen processing, confirmatory testing. It might be rapid test kits. It might be funding or immunization for the population that's incarcerated. It also might be materials or supplies for the prevention, treatment, and care of viral hepatitis and or HIV and STI, since we're having a syndemic approach here. And there's also other services that you might want to happen in a correctional facility that might come with stuff, that might come with, supplies or direct funding to do that. But again, it's this relationship, it's the subgranting, subcontracting, MOUing in which Section 318 funding is being provided that grants us eligibility. So once a correctional facility is eligible because of a partnership with a viral hepatitis program, it's important that the correctional facility meets the patient definition. And when the correctional facility becomes 340B eligible, enrolls in the program, and is then the covered entity, it is the correctional facility's responsibility to meet this patient definition. So I'm going to talk a little bit more about kind of the different roles and responsibility between a viral hepatitis program and then their partner, the Department of Corrections or the correctional facility. But at the service level, the patient definition needs to be met. So this means this would be the responsibility of the correctional facility. And correctional facilities meet the patient definition fairly easily. 1 and 2, they just do inherently. It's the legal requirement and responsibility of correctional facilities to provide adequate medical care to those incarcerated within their facilities. Their correctional facility or their medical contractor, if applicable, also maintains medical records for all incarcerated individuals. They just do this. They have to do this. And number 2, correctional facilities have medical personnel on staff, or they pay a medical contractor to provide those healthcare services that they're required to provide. And when we're talking about 340B, it's important to note that when a correctional facility utilizes a paid contractor for medical services, that the correctional facility should be the covered entity, not the medical contractor. The responsibility for those incarcerated always stays with the correctional facility. Also, the responsibility of care stays with that correctional facility, regardless of who the medical contractor is, regardless if the medical contractor turns over, it's the correctional facility. So I just want to make that clear as well in 340B. And then number 3 in this patient definition is where you as health program administrators, program managers, coordinators, this is where you have a lot of discretion. So to be 340B eligible, incarcerated individuals or patients must receive healthcare services or a range of services that are in line with the grant. This means the screening and treatment of viral hepatitis, HIV, STIs, again, we're taking a syndemic approach here, upon intake and throughout the duration of incarceration and following CDC guidelines. So to meet that patient definition, all 3 of those elements have to be met, and they have to be following CDC guidelines. So we'll talk a little bit more about that when throughout this webinar. But I wanted to highlight that both of those things have to happen. The correctional facility has to be eligible, and they also have to be serving patients or eligible patients, because that definition has to be met for 340B eligibility to be met. I kind of already talked about this, but again, partnership support, and we're going to highlight an amazing partnership here right after I'm done talking. But it really just varies across the country and from program to program. It really depends on what interventions the partnership is incorporating, what services you want to expand, what services you want to improve, often what resources you have available to support a partnership. Viral hepatitis programs and other prevention programs, are not always the most resource-rich programs, but if there is brochures laying around, condoms laying around, extra test kits, money for, any personnel, partner services, anything that would be within the scope of the grant, we see shared with a correctional facility and partnership support. And really, because of the high prevalence of viral hepatitis, HIV, and STIs in correctional facilities, the opportunity to implement any high impact intervention is really rich. Any collaborative partnership with correctional facilities will be beneficial to prevention programs. Again, in-kind support, I have listed here. And again, this slide is showing what funding might be used for. If you don't have funding lying around, this is the stuff. This is the in-kind contributions. And again, the in-kind contributions have to be purchased with eligible funding. So you can't use your state funding. You can't use additional, different types of funding. It has to be Section 318 funding. It has to be from a grant that is 340B eligible, because that's the eligibility you're passing on to a correctional facility. And I want to highlight the amount of correctional facility partnerships that are around the country. These are the states here that currently have Department of Correction partnerships in some capacity. Some of these states have prison partnerships. Some of these states have jail partnerships. Some of these partnerships are not statewide and they just might be in a county jail, but I wanted to highlight that this work is happening. It's happening across the country. It's making a big impact. It's allowing correctional facilities to treat more individuals for viral hepatitis. It's expanding services. It's improving testing. It's taking down barriers. It's saving an insane amount of money so that services can be expanded within the correctional facility. Which brings me to 340B cost savings. So I always like to say that this is the biggest carrot. This is the biggest incentive, is the amount of money that a correctional facility or a 340B covered entity really can save. When you look at the cost difference between a 340B medication and a wholesale or retail price medication, there's a significant amount of savings here. So if you're having struggles getting your correctional facility to treat appropriately, if you are struggling and fighting with them to expand treatment, if they are currently under litigation or being sued because they're not providing treatment, the 340B drug pricing program allows significant cost savings because they're serving as a public health covered entity. They're serving a purpose for your program. That's again, the scope of the grant is really describing the patient definition. And it's best practice that those cost savings are reinvested back into anything that's within the scope of the grant. So, it looks different for every correctional facility. It looks different for every jurisdiction, but our recommendations are that they expand testing, they expand treatment, they follow CDC testing and treatment guidelines if they're not already. Cost savings should support prevention programming within the facility. This, like I said, it looks different across jurisdictions, but sometimes they might utilize 4th generation HIV tests. They might provide testing to everyone, regardless of age or gender. They might update their protocols and they might update their testing algorithms. They might offer antibody testing and NAT testing instead of liver enzyme monitoring. They might start providing multi-site testing for STIs. They might provide ongoing opt-out testing throughout the duration of incarceration instead of just upon entry. We also want to see treatment expanded. We want to see first-line therapies implemented. We want to see exclusionary criteria removed. We want to see medication provided to support a person if they're being released. So we want continuity of care. Also, cost savings might provide an opportunity to implement prevention programs within the facility that have historically been cited as impossible to implement because there's just no funding for it. So if you have a medication line item in a budget and it's $1 million, and all of a sudden you save so much money that you're not going to use that $1 million, you're going to use $250,000 of that $1 million. Now you have a whole bunch of resources that you didn't have before. So we've seen some correctional facilities start providing safer sex supplies within the facility, safer tattooing and piercing supplies, safer injection supplies. Some correctional facilities might start treating substance use disorder while incarcerated or upon release. Some correctional facilities start providing Narcan within the facility and naloxone upon release. Also, cost savings can support linkage to care, including bridging services, ensuring engagement into HIV, STI, or viral hepatitis prevention or care follow-up release. Cost savings can be used to provide sufficient staffing to support these expanded syndemic services that I've been talking about. This includes administrators, pharmacists, clinicians, mental health professionals, case managers, educators, disease intervention specialists, and really providing any supportive services that address the social determinants of health and health disparities and reduce recidivism, because all of that is tied in to viral hepatitis morbidity. So again, no one's generating revenue, no one's making money, they're saving money in already appropriated budgets. So the 340B program just opens up a new pricing level of the medications that a correctional facility is already purchasing. If all of this 340B sounds like a different language to you, we have resources to build up your 340B capacity. I've listed it here and we're going to drop it in the chat. Lots of helpful resources are within this resource. There's a guidance, there's a webinar series. You can hear me talk for like, I don't know, 5 or 6 sessions. I'm sorry in advance. You can also request technical assistance directly from us here at NASTAD. There's the email right there. And I'm really excited to highlight some local programming. So in summary for me, before I pass it on to Rob, correctional facilities are valuable partners in public health work. They provide an opportunity for screening, testing, and treatment for viral hepatitis. Partnerships with correctional facilities might look different for every jurisdiction. A partnership may have larger implications than just programmatic work, providing correctional facilities with access to deeply discounted medications. 340B correctional facility partnerships can mean improved services. They might mean that you now have some discretion and some direction, and you can increase screening and treatment by utilizing this program and extending eligibility to your correctional facility partners. And health department administrators should communicate with one another to ensure syndemic services are being considered and implemented, because it's not only the viral hepatitis program that is receiving Section 318 STD 340B eligible funding. And last, I'll just drop this promo here. We have a resource, again, different learning modalities. If you don't want to, watch webinars, there's going to be a beautiful written guidance to talk about more in depth everything that I've given a short 15-20 minute overview in this webinar. It's going to be coming out in the next couple of weeks. Keep an eye out for it on all of your listservs. And it'll provide a lot of support to you all. And with that, I think I am going to stop sharing and pass it over to Rob.
Hi, everyone. Let me get my screen shared here. My name is Rob McGoey. I'm the Viral Hepatitis Prevention Coordinator at the Colorado Department of Public Health and the Environment. My pronouns are he, him, his, and I'm excited to share with you all about our collaboration with the Colorado Department of Corrections around helping them enroll in the 340B program. So just an overview of hepatitis C in Colorado prisons between 2017 and 2021, state and federal prisons accounted for 22% of all hepatitis C diagnoses in Colorado. That's more than any one county in Colorado. And again, between 2017, 2021, 11% of all acute hepatitis C cases came from, were diagnosed in state and federal prisons. And the vast majority of all of these cases were state prisons, as there's only a couple of federal prisons in Colorado, and they have a relatively small prison population. So there were nearly 2,700 chronic hepatitis C cases in state prisons between 2017 and 2021. And it's hard to say exactly how many people are living with hepatitis C in Colorado prisons, but in 2018, there was an estimate that about 2,200 individuals were living with hepatitis C. And if you compare that just to the number above, you can kind of easily see that there's constantly new people entering the system who are living with hepatitis C. And there are many people also who are leaving the system, and many people who are being treated, and unfortunately a few people who are dying of who are living with hepatitis C. So if I were to make an estimate or a guess of how many people are currently living with hepatitis C in the Colorado Department of Corrections, I would say that 2,200 number is probably still not too far off what it was it's probably still relatively accurate and comparable to what it was in 2018. In terms of care provided in the Colorado Department of Corrections, I think based on my knowledge of what's happening in other states, I think it's fair to say that CDOC is ahead of the curve. So for many years, they've been providing opt-out testing for hepatitis C and hepatitis B during intake for everybody who first enters prison in Colorado. And they also provide opt-out hepatitis A and hepatitis B vaccination during intake. In 2018, there was a settlement reached with the ACLU, and the state legislature allocated $41 million for hepatitis C treatment. And that resulted in DOC's ability to greatly expand hepatitis C treatment for anybody living with hepatitis C. They were supposed to spend all of that money in 2019 and 2020. That was disrupted by the COVID-19 pandemic, and the state legislature continues to allocate a significant amount of money every year, specifically for Hep C treatment in the state prisons. I believe it's around $8 or $9 million right now. And as a result, there's been a little over 1,200 patients who have been cured of hepatitis C as of June 2022. So because of all of this, because hepatitis C was already a priority for Colorado Department of Corrections, they wanted to figure out better ways to use that money. And here's a quick rundown of the collaboration timeline for 340B. So it started in summer about a year ago when I was forwarded a voicemail from someone who was a pharmacist in DOC. That was Dr. Michele Gard, who's on the call with us today. And I'm hoping to have her talk about her experience with this process when I'm done talking. So Michele had already been doing a bunch of research on 340B and was interested in finding someone within the state health department who could help them get their eligibility. So provide the in-kind support that Erin described. When I got this voicemail, I thought this made perfect sense for us to do it on the viral hepatitis team, because we knew that hepatitis C was still a major concern within Colorado prisons, and this would be a way that would allow them to expand services and care, and for us to work with them to figure out the best way to do that. I really didn't have a good understanding of what was involved in this process, though. Michele had already been doing a bunch of research and provided me with a lot of that information. I also reached out to NASTAD and other folks in my office to get a better understanding of what was needed to be happen. And by October of 2022, DOC was able to enroll in the 340B drug discount program. Following that, we started drafting an interagency agreement that would establish our obligations as the state health department and DOC's obligations regarding participation in 340B. I think it's worth pointing out again that this interagency agreement came after DOC enrolled. And a big part of, and I think that's worth mentioning because a big part of my hang up at first, of what felt very challenging for me at first, was understanding, was thinking that a formal agreement would need to be in place before DOC could enroll in the program. That in fact was not the case. What we needed to establish was that CDPHE was indeed providing in-kind support for CDOC. And we already were working pretty closely with DOC. We had a good working relationship with the Department of Corrections epidemiologist, and regularly communicated with him regarding case ascertainment, questions of technical assistance. And the request from DOC for help with 340B enrollment also coincidentally coincided with the discovery of a outbreak of hepatitis C cases at a DOC facility. And as a result of that, we started working very closely with DOC regarding outbreak investigations, case ascertainment, providing technical assistance and recommendations. We also helped secure some funding for a hepatitis C prevention peer education program and provided them with rapid hepatitis C test kits. So there were already a bunch of ways that we were already providing in-kind support for DOC. And what was needed for 340B eligibility was us to simply attest to that fact. Again, some other ways that we were helping DOC was encouraging them to expedite treatment with updated protocols for treatment of acute hepatitis C cases, and helping them with a campaign, so to speak, of publicizing the availability of hepatitis C testing at the impacted facility. And we started also working with the Department of Corrections on department-wide changes, such as the previously mentioned peer education program, which is still in the works of being implemented, expanded hepatitis C screening and testing, helping them explore options for expanding the medication-assisted treatment, and again, updating their protocols and procedures for acute hepatitis C. And just to circle back around to the expanded hepatitis C screening and testing, so this would be testing that was not only at intake, but also offering a brief hepatitis C screening at every patient encounter. And that kind of serves two purposes. So one, it allows for DOC to meet that patient eligibility criteria that Erin mentioned. And then it also allows people who may have missed hepatitis C testing at intake, or maybe who are concerned that they've been exposed to hepatitis C while in prison, to also be tested. Now, while we were already providing the in-kind support that was needed for patient eligibility, or for 340B eligibility, we still wanted to formalize an agreement so that we could help direct how this future funding from the future money saved through 340B would be directed. So we started working on we started collaborating with DOC around interagency agreement. And this agreement has still not been finalized for us, but it's getting closer and closer every day now. Our starting point for the agreement was Hawaii's DOC Department of Health Memorandum of Understanding for 340B. So shout out to Thaddeus and everyone over in Hawaii. We did end up changing things pretty significantly from that, though, and our focus, we decided we wanted to figure out a way where this could be part of an ongoing collaboration. And since DOC was already doing a lot of the most important things regarding testing and treatment, we wanted to kind of lay a foundation that could grow and hopefully expand in scope to include hepatitis B, HIV, STI, and including to improve care for hepatitis C. So the interagency agreement is kind of boils down to these obligations. So on DOC's part, their obligations include creating or updating protocols that include hepatitis C testing, treatment, and post-incarceration linkage to care. And we're setting certain standards for what's expected of that, including treating acute cases of hepatitis C and not just chronic cases, including this expanded testing for hepatitis C, and also that DOC actually implement these protocols. And then finally, that DOC provide us with a viral hepatitis report annually that would include things like a care cascade, how many people are receiving testing, how many people are estimated to be living with hepatitis C in each DOC facility, things like that. And then for CDPHE's part, our obligations would include providing the in-kind support that was described before, which includes technical assistance, lab test kits for hepatitis C, and case ascertainment assistance. And then also that we attest to Colorado Department of Corrections 340B eligibility when we're asked by HRSA. And there was a couple of questions that Zakia shared with me regarding a technical assistance request on this topic. So I thought I'd try to address those here. So one was, who needs to be at the table for these types of partnerships? For us, it really has just been CDPHE and the Department of Corrections. And really, we've been talking to the medical staff over at CDOC, and it's really been our office, the Office of STI, HIV, viral hepatitis, who've been having these discussions. But I did want to say that NASTAD has been a huge help. So thank you to Erin and Zakia and Isabella on that process. And the other question here is, who's responsible for ensuring compliance? And most of those responsibilities do fall on the Department of Corrections. For our part, CDPHE, we just need to attest to DOC's eligibility, provide the in-kind support, and then we'll also be overseeing this interagency agreement. And that's all I have. And I did want to open it up to Dr. Michele Gard to see if she would like to share a little bit about her thoughts on this process of DOC enrolling in 340B.
Okay, if everyone can see me, can you all hear me? Okay, thank you, Rob. Thanks for that presentation. And I agree with everything you said. That was a good description of how we established that relationship and how we've become enrolled in the 340B program. So just like Rob said, it really is dependent on that relationship with the health department, so CDPHE in this case. Just a little bit of background. So I've been in this position with the Department of Corrections for a little over a year. My position is relatively new to the department. It was a newly established position. And so when I was brought on, one of my duties was to kind of come up with ideas as far as high cost medications and how we can utilize our money, our budget and everything a little bit better. And I remember learning about 340B in school when I was in pharmacy school, but we didn't go into a whole lot of detail while I was in school. My background is more inpatient and outpatient. So I've seen 340B kind of in the works, but never actually involved in the actual implementation process. And that was the hospital setting. So a setting where they had already met that criteria. So when I was hired on and kind of was seeing the expectations of the job, that's when I had come across a YouTube video that was titled, let me pull it up, 340B in correctional facilities, I believe. And that just gave a good, or it's demystifying 340B for correctional institutions. So that's where the idea of this in-kind support, this relationship with CDPHE kind of came about. And just like Rob said, because a lot of numbers aren't listed per se, I just kind of started calling different employees at CDPHE until I got to someone who would take my call, and that was Rob. And so that's how we established this relationship. We chose to go the Hep C route for a couple of reasons. One, it was something we had already been in the process of implementing and improving. But additionally, the requirements are a little less aggressive than those with STIs, but we do kind of have a dual purpose questionnaire that we are asking all of the offenders at least annually, that also incorporates some STI questions. So that's a little bit of background. Like I said, once we established that relationship, realized that we could move forward with this, at that point we had already kind of come to the terms and agreements, and realized that we already had received some in-kind support. So we just had to tease that down. Again, the formal agreement started to be written. With state agencies is a little bit more difficult. So we did start as an MOU that changed to a statement of work. And again, it was a process of making sure everything read correctly and was worded the way that, again, a state agency. So that was a little bit difficult. But as far as the actual registration process with HRSA, that was relatively straightforward. We did need the notice of opportunity of funding number from the grant. But again, we had that relationship established with CDPHE. So we were able to get that information relatively easy. It does take a couple months for HRSA to approve the application and move forward. But again, that portion was relatively smooth. I'd say the hardest part so far has been just developing those policies and procedures and interagency agreements. So there are templates out there. Erin, you had shown an example, and I think you all are the ones who have generated this, but there are policy and procedure templates. Apexis, which is the governing or auditing agency, has one, and so does the National Coalition of STD Directors. And those are really, really good just to take you almost section by section to make sure you're hitting all the important points. But yeah, I'd say that's been the biggest struggle. So we've actually been, just like Rob showed, approved by HRSA as of January 1st, 2023 to begin purchasing. But as of today, we have not actually started making purchases. That's just because we're still working on our own policies and procedures and just making sure that senior leadership is aware of all the ins and outs and kind of going through all of that. Does anyone have any questions, or is there anything that you want me to hit that I didn't speak to?
I have a few questions in the chat, and Michelle, maybe while you're unmuted, I'll kind of jump around and pick the ones that you can answer. We are wondering if there is any kind of psychosocial support and intake for anyone who receives a positive communicable disease result or a positive viral hepatitis result. What will that look like for you?
So we have mental health on intake. They see and evaluate all of our patients on intake. So that's part of it. We definitely have this in, the provider's workbook as far as what that conversation needs to be like with the patients when they do have that positive diagnosis, and just taking them through the treatment plans and everything. But it is an open conversation with the patient. And as far as resources go, I know we've been in talks with CDPHE also. Some of our resources prior to this were a bit outdated. So that's one of the benefits also, is just in patient handouts that we've received.
And Michelle, can you clarify if your Department of Correction has in-house medical services or if you have a contract medical provider?
So we have both employees and contracts. Those are mid-levels and physicians. We do contract out certain services, just like the specialties. So whether that's dermatology, rheumatology, GI, but we do have an in-house pharmacy. It's a single pharmacy. And this was something that we had to change in our registration. So something to note is we have a single in-house pharmacy that then dispenses the medications to all of our, I believe, 18 facilities. So registering each of those sites has to take place in HRSA. we have our, again, in-house pharmacy under one location, and then the shipping locations are the other facilities, and then explaining that to HRSA had to take place. But that makes it easier. Again, you mentioned the three-pronged patient definition. So like you said, 1 and 2 were easily met because we do provide the care of all of our offenders, and we retain that medical record. Again, there are certain things that we have outside consultations. So again, like ID, all those, but they are still under our care. And our providers actually rewrite those prescriptions. Our pharmacy system is kind of a locked system. So only providers within CDOC can actually prescribe to the pharmacy as well.
Thank you. And I also saw in the chat, and I want to address this and take space for this, but several of you have mentioned that your correctional facilities might not be following CDC guidelines, and they might even cut communicable disease health care or health promotion or testing or treatment. And I want to really emphasize that correctional facilities do not get 340B, STD 340B without you. So if your correctional facility is not being a good partner, if they are not doing what they should be doing that is within the scope of the grant, if they are not meeting that patient definition, you have the power, authority, and ability to end their access to 340B. So this is why you have MOUs. This is why you have contracts. This is why you outline what they should be doing. So I would recommend that you go to these documents. You see what's in your MOU, you see what's outlined, you see what they've agreed to, you see what you have written down that's within the scope of the grant. And I know there's a little bit of political powers here at play. So maybe you're not able to terminate their 340B access, but you need to bring this topic up. You need to raise these conversations. You need to raise these concerns, because again, this is the reason they have 340B. This is the reason you are the gatekeeper. You at the administrative level, you are in charge of this partnership. You are in charge of your partners. If someone is accessing 340B under your grant number, under your no phone number, under your in-kind support or your direct funding, and they're not doing what they should be doing, then they don't get that cost savings. I don't care if they had a lawsuit. I don't care if your executive director tells you that you need to. That's not in compliance with 340B. That's not within the intent of the scope of the grant. That's not within the spirit of the 340B drug pricing program. So I would take some actions. I would look up your MOU, like I said. I would discuss with your PI. I would discuss with who's been involved in these conversations. I would be raising new conversations. I would be raising new concerns, because you have leverage here. You're not a bystander. You're not a passive participant. You are the state level program administrator. So again, you do this in writing, right? I mean, as a former bureaucrat, it starts with conversations, it starts with emails, it starts with partnerships. This is kind of, the soft touch of partnership. So maybe that starts first. Maybe the emails start, the conversations start, then you need to revise MOUs, put it into contract writing, really make it quite clear of what the expectations are here. And like Rob said, you don't have to have an MOU to enroll. Like if you're eligible and you can prove you're eligible, you're eligible. An MOU, a contract, or a sub-grant really formalizes that. It puts it in writing. And that's to the benefit of the covered entity, because that's very clear that they're eligible because they have a government document here. It's signed by everyone. But also within that, you can have that control, that discretion, that guidance. And again, you can still have that without an MOU, because number 3 of that patient definition, if they're serving ineligible patients, if they're not doing what's in the scope of the grant, then they're serving ineligible patients, and that's an audit finding, and they would have to pay back all of those medication savings. So it's on both parties' benefit to understand how the patient definition is being met, making sure they're serving patients within the scope of the grant, that they're using their medications for the scope of the grant. So I just wanted to hop on my soapbox really quickly there to really highlight that, and I've said it in my webinar, you're holding the velvet rope to a really cool club. The really cool club is the expansive medication savings that these facilities have access to. They don't get that just because they were sued. They don't get that just because they exist. They get that because of your partnership. They get that because they're serving a public health function. They get that because they're doing services that are within the scope of your grants. So I'll hop off my soapbox there. But I don't know if Rob or Michelle, you have anything to add on that.
I did want to say, and you kind of brought it home there at the end, is the relationship with CDPHE or with your health department. It's like you said, it only gets us so far. They're the key into the club, but once they're, you know, we don't have free reign. So that's where it becomes diving into the policies and procedures. Just like you said, you know, parts 1 and 2 of that patient definition are pretty easy. What we've been finding is that part 3 has been a little bit more difficult, just because you need to make sure that each medication that you're looking at purchasing then still meets the 3-prong patient definition. So for us, it's being Hep C. That's why we've implemented a questionnaire, and it goes into each visit. So it's asking the patients, I'm not going to go through the exact questions, but it's a Hep C screening questionnaire. And at minimum, it needs to be at least annually, but we're doing the questionnaire at all non-emergent visits. And that's how we are showing that this 3rd part of the patient definition is being met. But just to say, you know, oh, we have this relationship established now, does not get you access to these medications. I mean, Hep C medications are one thing, but because they're, you know, going through all the testing that goes with that, but to go any further, you really need a lot more in the policies and procedures to be able to purchase those medications. So just like you said, it becomes a bit more involved the further you want to go into that. And that's where that relationship's really important too, just to make sure that we're in line with all the most recent, you know, CDC guidelines, and that everything's in line with that agency that you're partnering with. But then beyond that, it just needs to be your own agency that's actually responsible for following the policies and procedures and what HRSA and Apexis have laid out, if that makes sense. They can only get you, like I said, into the club. Once you're there, you've got to be able to stay there.
And also you're responsible for your club participation,
Exactly.
right, Michelle? Like you're responsible for how you're using it, what you're doing, not getting kicked out, compliance. Rob will stand there and wave at you as you're having an audit and give you moral support, but he's not the one being audited. So that's a really great point to highlight as well. And I see one other question, just maybe we both kind of talked about this, but maybe we can reiterate. What funds do you have for the support of in-kind, and how can Section 318 funds be used for in-kind services? So I don't know, Rob, if you want to kind of reiterate the in-kind you're providing out of PS 2021-03.
Yeah, so the in-kind that we're providing would be case ascertainment, technical assistance, and test kits. Now, case ascertainment, because our case ascertainment specialists their salaries are paid for through PS 21-2103. That is one of the Section 318 covered grants. And because my salary is paid for through PS 21-2103, the technical assistance that I provide would also be a Section 318 covered grant. Now, technically, the test kits that we're providing, we're not using PS 21-2103 dollars for those. We're using, I guess it would be state opioid response dollars, but we are still providing staff time to order those tests, to get them, to coordinate with the OC, to get them to the facilities, and providing technical assistance in terms of information on how to utilize the test kits, run controls, things like that. So my understanding from Erin is that all of those things count as in-kind support.
And I
And
just
I'll
dropped.
just say too,
Oh, go ahead, Michelle.
that's been huge for us as well. So that's been kind of something that we didn't think about initially, but as we've had like Hep C outbreaks, We've now implemented those rapid Hep C kits, and it's been really invaluable in terms of just, being able to respond to those outbreaks, being able to test more individuals. So again, something that has come from this relationship that is not just in terms of medication savings. So that's been really nice. And we've also, as part of our agreement, in terms of the information that we're required to share with CDPHE, as we've kind of gone back and looked at our Hep C numbers. And that's really shown us 2 areas of improvement as far as, okay, did they get all the testing to confirm that they were cured, different things before that litigation occurred. So this has really, again, improved our Hep C management overall. Again, hoping to here soon begin to actually purchase these medications and get some cost savings, but just overall improvement of care has already taken place.
And I dropped in the chat the HRSA definition of in-kind. So I just want to remind everyone that in-kind contributions may be in the form of real property, equipment, supplies, and other services directly benefiting and specifically identifiable to the project or program. So as long as whatever your in-kind you're thinking about fits within that description, you're good to go, because that's the HRSA definition of in-kind. And I know we're close on time. We have 1 minute left. So Zakia, do you have any closing items? I'm going to drop, again, the resource. I see a few questions about how to identify Section 318 eligibility and how to leverage your grant funds. So that can be found in the 340B drug pricing program guidance for viral hepatitis. So I'm going to drop that in there. I would recommend everyone checking out that guidance if this is leaving you with more questions, but I just want to be mindful of time. So Zakia, do you want to jump in here?
Oh, hi, everyone. I just want to say thank you so much for our presenters, Erin, Rob, and Michele, for leading us through this great discussion about 340B and corrections. I know that this is something that a lot of jurisdictions are considering embarking on. So thank you all so much for sharing your expertise and your experiences with implementing 340B. Like Erin said, we have our 340B resources available in the chat. And also, if you all need any TA regarding 340B, please reach out to us and let us know. I think we have like half a minute left, so if there's any other quick questions, we can do those, but just want to thank everyone for joining us and thanking our presenters.
Thanks, guys.
All righty, well then I guess we can end for today. Thank you all.